Hello, everyone. We thought we'd start a little bit early and kibitz a little bit before we hit the top of the hour. I see everyone's telling us where they're from. Thank you. We love that. And how are you doing, Miss Alicia?
I am enjoying the weather.
The cooler weather?
Yeah, we know this is the time of year that the new codes come out every year, so we don't have to be evergreen.
Right.
And it's nice and warm in the middle of Missouri in the afternoon, and it's quite crisp in the morning and evening. Well, I'm enjoying that.
Yeah, it's like that here in Florida, like this afternoon it was gorgeous, like 73 degrees, but early in the morning it's cold. And you have Florida kids when they're like, Mom, can you give me a ride to school? It's too cold to walk. You don't know what too cold is.
Yeah, really. My son dropped me off at the office, and he came in with me, and he said he turned the car off, and he said, "Look at the steam coming out of the muffler." It's just because the muffler was so hot. So that was
Yeah. Wow.
And our colors have already popped, and they're pretty much over, and the leaves are falling on the ground. I'm curious how many people, talking about leaves, how many people rake their leaves and how many people leave their leaves down? Because we don't rake our leaves. I like them to stay, and I like walking on them and it being crunchy and everything. And there's people that are really dedicated. They rake them all into a pile. I'm curious. Yeah, Margaret says she rakes.
Yeah.
We did a little bit when the children, Shelley leaves them. When the children were young, we would maybe rake them into big piles and then everybody play, but we didn't do it for.
I think it depends if you're more rural or not. Like where we lived in New Jersey before, like you had to do it. It was just crazy. And now here in Florida, the leaves don't fall like that. We're in an HOA and you can't get away with that kind of stuff.
That's true. That's true. I would say that has to be true. I didn't think of that. Yeah.
Very good.
There's old Sarah from Missouri, my neck of the woods.
Sylvia says she leaves them. Hi, Sylvia.
Yeah.
So tonight we're doing can you go to the next slide there, Alicia?
Sure.
I think that's the one so tonight we're doing the 2026 CPT update that has been sponsored by Find a Code. So they helped us to get the CEUs from AAPC or the CEU. The way that you will access it when you're done, whether you watch this as a recording or you're on with us live, you're going to go to cco.community. It might need to be www.cco.community, and you'll see where we have the free CEU section over on the left. But please give it, I'd say, a day or two before the CEU quiz is available. I don't think Mary's put that in. She normally waits till after the live event so that the recording is there. So I would give it 48 hours and it should be there. There is also last year's 2025 CPT update that's going to be expiring, I think, the end of this month. So if you want to do that one real quick and get the CEUs for that and then get the CEU for this, you can do that. There's always that kind of overlap period. And Alicia was reminding me last year we did it in, I think, January.
Right.
So we already had access to the codes in Find a Code. But right now, today, what is it, November 13th, we only have the preview. But it's enough to get us in and show you what we need to do. And Alicia's going to be doing the presentation because I've been sick and I'm very medicated right now. So I'm just going to be Vanna White in the background.
And it was interesting that we have all this stuff ahead of time. We've already done ICD and now doing CPT because historically we have always right at the first of the year. More ICD comes out first. So we're able to present that early, but CPT comes out a little bit later, and then HCPCS doesn't come out until December. There's usually not a lot of changes. It's something everybody can usually tap into that, and it's not difficult to catch up. Oh, I'm seeing more names I recognize. Yay! And we're doing good on time at 7:02. We can officially get started.
All right. Take her away. And
Now,
if you have any questions, Alicia's doing the presentation, just pop them in the chat and I'll pull them in at the right time. So don't be shy with your questions.
yes, the print is a little finer and I had to put on my computer glasses to be able to see. So I've got it on the big screen. So just forgive me if I'm like watching tennis here, going from one screen to the other. We do want to do a quick reminder that the CEU, that is all in the club area, and you will be able to pick that up once the quiz is loaded. Now, let's talk about CPT and why it's really important. I know this is a refresher for some of you, but we also often have a lot of new people and maybe some people interested in getting into our industry. So let's do that refresher and let's talk about why the CPT codes are truly important. First of all, the code sets are another language. And if you want more information about the code sets that we've used, we did a webinar here recently about the code sets, all of the code sets. So I'd encourage you to go check that out. But it's a uniform language. And what it does is it allows us to talk and translate without having to use all of the documentation at once. It also allows us to maintain patient information, and there's continuity involved. And we can, now that everything is more electronic, we're able to pass that information from one entity to another. So if I were to go visit Laureen in Florida and I were to catch a bad cold, then I could go see a doctor there and they could pull up my record or tap into my record electronically to see if there's a particular medication I'm allergic to. So that is at easy access at your fingertips, unlike what it used to be. Now, that is one thing about CPT and the language of medicine, that we can transfer that information back and forth. But we also have to remember that it's more than that. It's the foundation of value-based care. It also involves research, benchmarking, and preventative care. So let's talk about value-based. That means that whatever we do to the patient, we have to substantiate that with the diagnosis. So we have the CPT is all about what's done to the patient, what procedures are done, even if we're evaluating the patient or monitoring the patient. And then research. We know because of CT that we can link a diagnosis with the ICD codes. So if a patient has, say, an aortic valve issue and it needs to be replaced, that's the diagnosis. But how are we going to do that? The CPT code will show how that's being done. And through research, we're able to tell when it should be done, and also what valves to do for what particular diagnoses, and also all of the steps before you get to the point of replacing. So that means we need to have an echo, you might have to have ultrasounds done, maybe a stress test, all of that stuff builds up in a CPT. So that's done on research. Now, benchmarking is how we evaluate and compare other people. This is really often done with E&M. And we can take say your primary care provider, doesn't matter where you're located in the United States, but we can show a benchmark on how many level 3s, 4s, and 5s in established patients, as well as new patients, and how they compare with their peers where they're working, as well as nationally in the same specialty. And that way you can tell, one, is it a documentation issue or is it a coding issue if you're not meeting the benchmarks? And then also preventative care. With CPT, like I said, with say a heart condition, if you have a propensity or a genetic disorder or family history for a specific diagnosis, we know what preventative medicine and steps need to be taken to make sure that you remain healthy. So again, it is incredibly important to be on top of what's being done to the patient. And that's what CPD says. It is the language of medicine. Now, with CPT this year, this upcoming year, we have a lot of changes. There were a total of 418 changes. There's 288 new codes. There's 84 deleted codes and 46 revision codes. If you had joined us with the ICD, CPT and ICD, the way they do the change is a little bit different because of the format that the code sets are in. With ICD, a lot of the new codes are codes that were, say, deleted and then expanded. So they were still the main basic code, but they were expanded to give more characters to show specificity. Say that they broke it down into 3 different specific types of anemia. A year or so ago, they came out with new obesity codes in ICD-10 so that you could do class 1, 2, and 3. Now, with CPT, you're not able to do that because the code set is not expandable. It's finite. You can add new codes, but you can't expand an existing code. And so deleted codes are truly deleted codes in that situation. But this year, we have a breakdown of effective January 1st, the largest proportion of the codes is going to be the lab analysis and category 3 service codes as the bulk together. And then 46% is all the other codes that are involved. So that's interesting to know. So we're going to start out by looking at the codes numerically. It's easier to do it this way. We know the CPT usually by the first character. So we'll say the 2000s, the 3000s, the 4000s, the 5000s, and we know what procedures or what's being done to the patient based on that first character usually. Now, that also means like when you see 99 codes, for the most part, not all the 99 codes, but they're usually E&M codes. And so that's easy for us to remember. So with a couple new codes in our 2s, they deleted 27445, but they replaced it with additional new codes. Now, let me explain, especially again for our new people, that when you delete a CPT code, it's gone. Okay, it's not being expanded. For the most part, they keep the codes, the numbers right there within the vicinity. So you notice 27445 will be deleted. That means that when you go to look it up, you won't be able to find any portion of that. However, the new codes are 27447, but the other new code is 27487. Okay, so that is the limitations of what CPT has because it's not expandable in that way. Now, in addition, 27468 was deleted, but there is no direct replacement. Now, we'll talk about what these codes are. With 27445, that is for knee arthroplasties. And then the 27468, let me just pull that up here real quick. And I'm looking it up and find a code, which I'll show you those in a moment. The 27468 is not going to be replaced, but it's an osteoplasty of the femur, and it's combined lengthening and shortening of femoral segment transfer. So in other words, they're saying they're not doing that anymore. There's not a code to translate for that anymore. Now they do, though, have another deleted code, which is a baby code or a temporary code, 0275T. When you see a code with a T at the end of it, that's what you think of it as a temporary code. Now, what happens with these codes for our new people is that as new procedures are being developed, a new way to treat a diagnosis, they will try out a code. So the description, the whole procedure. A lot of times it can be even new technology. So this is a temporary code. It's like a holding place. If it does well, then it'll be deleted and it'll be turned into a new code. So what they're saying is 0275T grew up. Now it's going to be in the 62287, 62330, and 62331. What is the new definition? It's going to be for percutaneous intralaminar lumbar decompression with laminotomy and laminectomy. Now, there's further information there. So if you are in orthopedics, these will be that 0275T that you've been using as a temporary code is going to get 3 codes to replace it with specificity. So if you do orthopedic spine, that'll be pertinent for you. Now we're going to jump right into vascular. This is when we're dealing not just with the heart, but the vascular system itself. When we say these codes on the left, they're deleted, but almost all of these are replaced with either a new code or a code range. The first one is 33884. Now, as we look at that, and I'm going to be listing these, but we're also going to talk more about them as we go. So I don't want you to think that we won't give you more insight. But this is for an endovascular repair, and it's the descending aorta. Now, as we look at that area, we always group codes. So these are 3388 codes. And in addition, for an open subclavian, the carotid artery transposition with endovascular repair, we now are going to use 35694. So that is a new code, just so you know. 33891, these are for bypass grafts. These are not veins, and transcervical carotid use, it's now going to be 35602. We're going to go through these a little quicker. I'm not going to read all of them. I'm going to do like a summary because you're going to have access to the slide deck. And quite honestly, I don't need to drone through these. What you need to know, and the takeaway here, is that these are vascular cardiac. This is what's changed in those areas. So if you do that type of procedures, if you're doing cardiac coding, surgery, or vascular coding, these are the ones that you need to pay attention to and take back to your office, flesh out, see what you need to do to educate the physician that's doing these procedures, especially if there's verbiage that needs to change, in addition, just to make them aware, as well as the coders, of these upcoming codes that's going to happen. Again, be very mindful of codes that are deleted, and 1 or 2 codes take their place. Find out what differentiates them. And then in addition, codes that are not going to be replaced. That usually happens when it's not being used enough. And we know this statistically, that it's not worth even keeping that code in the code set anymore. And quite honestly, I think they repurpose them after several years. I'm not sure, maybe not, but again, they could, but you wouldn't want to do that from one time to other. That could mess everybody up if you did it 1 year right after another one. Let's see the replacements for the 92921 codes through. So the 9292 codes. Let me just jump in real quick and look at those. We will talk about those more in depth. These are angioplasties. That's what I thought. So now you can see that, for example, 92921, you're going to use 92920. So you're in that same area. So if you're working with updating your CPT manual, it's going to be easy to do that. The documentation notes that you make for yourself can be right there. Let's see, they're not going to replace 92944. And notice 2 codes are being taken away, with only 1 replacement for coronary thrombolysis. More deleted codes in neurology and neurosurgery. We have some of these baby codes are now deleted. They grew up. So if you work with replacements of new Baraflex aviation therapy, or BAT therapy, not to be confused with the VAT technique that we use in our CPT manuals. Then your new code ranges are going to be 654 through 59 and 93145 through 6. We also have got a new code for ablation of malignant prostate tissue. This is called a HIFU, and it's now going to be able to be coded at 55880. Again, see how these procedures that they new things that come up to treat a specific diagnosis, prostate cancer, that now it's gone through the process, and it's used enough that it's got its very own code now. We've deleted a couple other 0662T and 0663T for mechanical scalp cooling, and they have their own codes, 97007 and 97009. And you think, why, what in the reason would they do mechanical scalp cooling? Pretty fascinating stuff. I know you probably had never heard of that unless you're working in that particular area, but there's several reasons that they do that. They put this calibration caps, and it's a lot of times used during chemotherapy treatments. Hopefully what they're doing is you don't lose as much hair through those treatments. So it's exciting. And then also percutaneous electrical nerve field stimulations. We have a new code 64567. Urology didn't get as much love this time. They deleted 52647, and also we now have we have a code range for the report of biopsy of the prostate. So again, if this is an area that you're working in, oncology or urology, then these are codes that you want to pay close attention to. And another thing that I'll give you some information or insight about for our new people, if you have noticed through the years, they take certain areas of the code set, both ICD and CPT, to expand on. They can't just do the whole thing all the time. So they take selective areas. And that's why I like to say that particular area got a little love this year, and in groupings of new codes as the industry changes as well. Again, prostate cancers, there's been some new treatments, and as well as research that, and some new medications and everything. So now the code set has to be able to be developed to translate that information. We have cystourethoscopy with balloon. Oh gosh, I don't know if I can say that. Commisurotomy. I don't know. For drug-coated balloon delivery. That is actually cool. The 52443. And another thing about these webinars that we do on these new codes, we can't go through them and give you as much detail as we'd really, because we'd be here forever. We can do more in-depth in areas, especially if you let us know ahead of time that's a particular area you want more information, we can do that. So give us a shout out in the chat if you see an area that you'd like a deeper dive into them. But there are some really cool male reproductive procedures for a lot of different diagnoses that have come out this year, where like Peyronie's disease and some other things that this is all related to. Now in the radiology, the seven codes and imaging codes, they deleted a bunch this time, but we do know, for example, the imaging, the 77014, I thought that was pretty interesting because we didn't want to get rid of that. That's where they do a CT scan and they place those radiation fields, set those up. So if you look again, they dropped that code, but now you're going to use 77387. Now we also got, and again, these are all imaging radiology. I'm putting these in here as we go. Oh, and that's intensity MRTs for guidance and tracking when performed. That's deleted, those two codes. However, we got 3 codes to replace that, and it's because they divided up specificity for body areas. So that's exciting. Then we got 3 new baby codes that Brachiotherapy, we can code for that now. Electronic brachiotherapy, CT for cerebral perfusion analysis, and transcutaneous hyperspectral imaging. To me, that sounds like otherworldly, right? We can do hyperspectral imaging. When we do these webinars, we really want you guys to jump out and do your own research. So we're giving you that heads up. Path and Lab, they had some changes, but with Path and Lab, what we find a lot of times are that new things that they're testing for come out. So we don't necessarily see a lot of those baby T codes, but we do see U codes. So with the section 024, that whole square there, they were all deleted. And from now on, you're going to look at the individual PLA replacements when they put those through. So I thought that was interesting. Now, let's talk about some of the highlights. Let's talk about more in depth about some of these codes. So again, we did a rough overview, gave you a heads up. Why are these being changed? And what do you need to know about them and take back to your office? Or as you, maybe if you're new and you're getting ready to test for in next year, that you'll have a heads up. They do test on new codes. Now, they don't exclusively test on new codes, but they do put them in on the exams if you're going to test from one year to another. The key highlights, they expanded the digital health and remote monitoring services, new codes for augmentative and assistive AI services. There's new hearing device services codes. There's comprehensive overhaul of leg revascularization codes, and that's why you saw some of those vascular codes that were deleted. Telehealth behavioral health appendix update. We will talk a little bit about telehealth, but remember, telehealth is this ever evolving behemoth, and just because we have a code for it doesn't necessarily mean it's going to get paid for, okay? And telehealth is an example of that. At the time that we're doing this presentation, know that the government has stated some mandates and changed what telehealth can be covered for, so that could change at any time. The coronary intervention codes, the deletions, they deleted the 929 codes, several of them. We already gave you a little review. But what they did was they used these as add-on codes for coronary stent procedures. Now we won't be doing that. They're replaced by new comprehensive revascularization codes themselves. So new codes are bundled. We're going to have primary and additional coronary territories. We did stent and angioplasty and atherectomy when performed, and improved alignment with current interventional cardiology practices. So again, if that's your world, this is what you need to pay attention to. Let your little coding spidey senses pop up, and you'll be able to look at the way that we're presenting that. And we encourage you with attribution to take this back to your offices. So with that leg revascularization, what they did is they took 46 new codes, they replaced and deleted just a handful, like 15 codes, with all of this, like 46. Now, they don't do that every year, but again, when you think about the vascular system, it's pretty expansive, and location is really important. So the bundles are now angioplasty, stents, and atherectomies are done with one code. Isn't that amazing? And then your add-on code is going to be for those territories when you're going to be looking at multiple territories. Now, if you're not in vascular, then it's not particularly going to make sense to you. You have to understand what territories mean. Now, again, as you look at these, you may consider taking our anatomy course, because we do touch on the vascular system in that. What they're doing is they're looking at more of these procedures not being done as inpatient but outpatient, and that's why the codes need to be spread out and individualized, because that's how you get paid. Whereas when you're inpatient, it's all bundled into one payment. And then also there's some new technology that's come out that has to be written into the code set for the use. We also are going to be working with some hearing device services. There's 12 new codes. They replaced like 5 codes for really outdated hearing technology. Now, just about anybody can get a hearing device and tap it into the phone. My niece has a cochlear implant, but even before she had that, she could take her hearing aid and tap it into her phone. But with a cochlear implant, it's like bionic. It's really amazing what she can do. These codes are going to be able to articulate that better. So now we're able to do digital and programmable devices. We couldn't do that before. And we've been using these digital devices for a very long time. So the code set finally is catching up with new technology. What this also is going to include is validation, performance checks, and training. If, say, you get a hearing device, then we need to check and make sure that it's performing accurately. They're going to be able to compensate now for them doing that, checking and making sure everything's working properly. If you start having some tones that you aren't able to pick up, they'll be able to check that through the device that you've linked it in. And then on top of that, think about this. Most people, not all, but as we start using hearing devices, it's usually when we start aging, our ears are one of the things to go. Technology isn't necessarily for that generation. They're not as tech savvy. And so training is really important. And then you should be compensated for doing that training. And then also when we are going to be looking at teleaudiology and smartphone integration, that's going to be addressed with these new codes. And the overall thought process is patient-centered. We want them to visually be able to use the tools that are given to them so they can hear better, the dexterity and the psychosocial factors involved with improved hearing or losing your hearing, either one. Radiation therapy codes that were deleted. Previously, we used for the intensity modulated radiation therapy, IMRT. They deleted this code range because the methodology is more or less outdated. Now they have a new updated reporting structure. They replaced the ability to be able to do advanced planning techniques, delivery of complexity, and technology-driven workflow. We've got a lot of new codes that are technology-driven that we saw this year. It's not surprising, and I think that you're going to see that more and more as we start using AI and extra tools to perform procedures. So a little overview of what we've covered so far. We have the coronary intervention codes that were deleted, what and how they're being replaced, and then what are the key changes. So for coronary intervention, we've bundled by territory, and that's going to include us to be able to use stents, angioplasty, atherectomies, all in one code. Again, never been able to do that before. I know several people that were excited about that. When we do lower extremity revascularization, again, it's territory based. We're going to be looking at iliac, femoral popliteal, tibial peroneal, all bundled with modalities. For hearing aid evaluation, we're going to be able to do digital and programmable devices. And a lot of thought went into validation, training, and technology, or excuse me, teleauditogy, I can't say it. And radiation therapy, they updated the codes to allow for modern planning and delivery methods. With AI, again, I just said that you're going to see a lot of new devices and stuff written into the codes as we get new technology being developed. And I personally think that rides on the back of AI. It's going to help us develop technologies and pinpoint ways or what the primary need is for patients. That'll be able to pick up on trends and stuff. So what they did with AI, there's a lot of new codes that are directly related to AI services. this is helping with physicians' capability to improve patient care. That's the ultimate reason. So now we can do coronary atherosclerotic plaque assessment. Before, they would go in and they would look and say that you had plaque, but for our atherosclerosis, but they couldn't break that down and give you more specifics. Now we can. And how are they doing it? They're doing it with AI. Also vascular fat analysis for cardiac risk. Notice AI is fabulous with trends, so they're looking for risk factors. We have a new temporary code for multispectral imaging for burn wounds and detection of cardiac dysfunction. What the imaging for burn wounds tells me is that next year, we're probably not in 26, but in 27 and 28, burns will probably get a lot of love, in my opinion. I could be wrong. Come back and let me know if I was right. So with telehealth and behavioral health, again, just because there's a code for it doesn't necessarily mean that you're going to get reimbursement, that the reimbursement follows. However, we need to be very aware because of telehealth. It's really linked with behavioral health. Even though after COVID, we use telehealth for a lot of things, now they're reining that in, but behavioral health is always going to be linked with telehealth. They expanded the appendix P&T. They now recognize audio and video and audio only behavioral health services. It's been a game changer for a lot of people's lives to be able to tap in to these resources. Improves access for rural and underdeserved and vulnerable populations. Remote monitoring codes. We got 5 new codes. These are based on days. So 2 to 15 days of monitoring within a 30-day period. We also got 2 codes for expanded monitoring. So that's 2 to 15 days and 16 to 30 days options. Monitoring is actually out there a lot more than people realize. I think that with technology and AI, we're going to see remote monitoring become a really big deal in the next 5 years. Every year you'll see it progress. So stay on top of that. What this ultimately does for our patients is it allows us to really take a deep dive on chronic diseases and management of those, and post-operative care, because a lot of people slip through the cracks on post-operative care. And then the goal is not to have them be readmitted with a complication. Enhanced treatment management. So we got a new 10-minute threshold code and revenue opportunity. They're going to average about $150 or a little more per patient per month, potentially, for remote monitoring. And again, to do that, you're going to have a chronic illness. They are now giving us 98979. This is going to be breaking the 20-minute barrier. New code for remote therapeutic monitoring. Time requirements is going to be first 10 minutes, and then that's versus that current 20-minute minimum. So that's interesting, because with technology, we can do this monitoring pretty quickly. Billing frequency is going to only allow us to do it once per month. And the interactive communication, at least one real-time interpretation is required. Reimbursement, 25 to 30, that's the national average. Of course, that could be tweaked and go up and down depending where you lived and what payers want to do. But with clinical staff, it can be performed under direct supervision. So that means a nurse can do this. It doesn't have to be a NPPA or physician. And then short-term monitoring. We've got 3 new device codes so that we can do shorter monitoring. That might be a blood pressure, or even probably not EKGs, I don't think, but now they've got the ones where you can just put your fingers on there. I see that coming. We've got respiratory monitoring between 2 to 15 days. We have musculoskeletal that's going to also be 2 to 15 days. Notice that these are day-based, not time-based. It's how many days a month that they can be done. cognitive behavioral therapy monitoring. The key difference is, again, is now we're going 2 to 15 days data required versus 16 to 30 that we had in the past. Again, I think this all it relates back to the development of technology and the AI being able to assist. There's clinical applications, so it has to be acute episodes, post-surgical, or medication titration. That's the only monitoring for short term that's allowed at this time, and you can only bill once a month. The comparison, again, before we had to do 16 to 30 days of monitoring, now we can do to 2 to 15. We're looking at acute care, post-op, and medication changes. There is long-term, for chronic disease management and maintenance care, but always remember that you have to have a revenue strategy. So match the monitoring duration to the clinical needs. So you're not going to have something that is 15 days when it can be done in 2. You're going to have to be careful with that, with the billing. We also have 99445, which is enhanced psychological data collection. This is a new code for remote monitoring. Again, same thing, 2 to 15 days in a 30-day period. This is that new shorter option that we keep seeing with these codes. The parameters, this can be for weight, blood pressure, pulse oximetry, and respiratory flow rate. There is a device required. It has to be FDA approved and automatic data transmission. So again, the device has to be involved. You can't just say that we're calling on the phone, what did your blood pressure read today when you took it? Now you got to put the device on, let it do the work, and then it has to be an automatic transmission. The billing frequency, again, once per month. Now, this is complementing the 99454 that gives you 16 to 30 days. Now we're going to be able to do 2 to 15. Unlike the others where it was replacing that. Okay. Clinic application, chronic disease management. Again, it's all about the patient. What are we trying to do? We want to manage the chronic diseases. And this really piggybacks off what we've learned through the last couple decades with risk adjustment, right? We know how much it costs to take care of a patient with specific chronic conditions. Now, how are we going to manage that? So diabetes, you can do glucose monitoring with the 99445 during insulin adjustments only. So the patient has to be an insulin dependent diabetic for that to be used. For hypertension control, we can do the blood pressure tracking, and it's post medication changes only. Again, we can't just keep using these because we're monitoring the patient because they're diabetic. They have to have, maybe they have to be on a tiered or a, what's it called? Titration. There's a name for it. It escapes me at the minute. Somebody can put that in the chat, what it's called when you're titrating up and down the insulin. The hypertension, again, you start a new medication and you want to see if it's working. Do we need to adjust the dose? Is their blood pressure coming down? Did it go down too low? And this allows us to check that. Switching from one blood pressure to another one. Sliding scale. You're right, Jamie. Thank you very much. That term was in the back of my head, but I couldn't remember it. Heart failure patients. With heart failure, it's really important that every single day they're weighed. And in addition, you're checking the vital signs because they can gain like 5 pounds in 24 hours or more, and that's fluid and showing that the heart is shutting down. COPT management, of course, they're going to do respiratory status with the 98984, but only during exacerbations. Arthritis care, mobility tracking with 98985, and mental health for depression and anxiety monitoring with 98986. So these are really cool that we're able to do that. And I think you're going to see this area expanded in the next few years as we do more and more remote work. We're really going to be able to tap in and see when somebody's having an exacerbation, or this also prevents them from ending up in the hospital. The clinical application for post-operative care, Orthopedics, the mobility tracking is going to be 2 to 15 days. For cardiac procedures, they can monitor the vital signs. Post-discharge respiratory surgery, we're going to do breathing patterns during the recovery phase. Pain management, there is a multi-parameter monitoring for optimal recovery. Now, I suspect that's going to need approved forms that the patient would work with. And then early completion detection for real-time alerts for concerning trends and reduced readmissions. Like I said a minute ago, enhanced monitoring improves outcomes. One, the health literacy is very important, and a lot of our patients don't have that. And it's not saying that they could have a cognitive issue, but it could just be a new diagnosis, or that has either slipped into the chronic phase or a new diagnosis. And we want to make sure that after they've had their treatment, that they understand the right questions to ask, and they have access to the clinicians to do that via remote, versus thinking that they have to come in for a doctor's visit when it's difficult to get out after you had surgery. So how are we looking at implementing these remote monitoring codes? First, it's only certain patients that these will work for. So you need to have a plan to identify who these patients are, and then set up the program. Device management, again, it has to be an FDA device with reliable data transmission. I know you guys know I talk about my son all the time that has epilepsy. Now he has a watch that is attached to a specific cell phone, and then it can alert all the rest of us, and it looks for seizure activity that we may not even be aware of, as well as track where he's at, and can tell if he fell down, and a whole bunch of other stuff. And we can do a whole report and bring that to the neurologist. So it's really cool. Staff training, we need to make sure that your clinical staff has a competency for monitoring and using these codes, because there are specifics, day specifics within a certain time period, talking about FDA approved devices, what diagnoses you can do it for and not. You can't do diabetic monitoring for that one code if they aren't insulin dependent. They're not applicable for that. Documentation, so you're going to be required to maintain detailed records for all the patient interactions. And that, my friends, makes me think of our QPIN course. That's what a qualified patient illness navigator does. They're that liaison for that interaction, making sure they're not going to slip through the cracks. You can get more information about that later. Alert protocols, make sure that you have clear response and procedures with the data. So if you have an insulin dependent and they're going through that sliding scale and you're tracking it, what's the protocol if they are without inbounds and not inbounds? Have that set up ahead of time before you start submitting these codes. Billing compliance, and remember that each of these codes have specific requirements to use, and make sure everybody in the office understands them. Revenue impact and optimization with the 98970. Again, we're looking at $25 to $30 per patient for routine management. Now, again, that will vary, but you want to have all your ducks in a row before you start submitting these codes. Also, with the short-term device codes, it could be anywhere from 40 to 45. So if you're set up to do this, it could be a really good revenue increase for the clinician as well as for the patient's health. The strategic cycling, use appropriate durations. The scaling, look at 100. If you look at 100 patients, that could be 150,000 annual potential. There are some combination opportunities you could layer with the CCM or the TCM and other care management codes, but ultimately, the goal is patient outcomes and value-based outcomes. Now, we have a lot of CPT resources here that you can look at the CPT codes, but I'm going to jump in to find a code real quick because we're so happy that and I think, yeah, let me just do that real quick. Pop in here. So this was one of the codes that I had looked at. What Find a Code does that is so great is they allow us to look at the new codes. A lot of encoders do this, but I really like the format that CPT does. Now, again, with CPT, especially for our new people that are getting into this industry, CPT is owned by the AMA and they have a copyright on CPT. So you can't use CPT codes willy-nilly. You have to usually sign in and click off acknowledgement when you go into programs to use CPT. They monitor it very closely. They're proud of their what they've developed. And so unlike with ICD, where you can go in and you can look at all the new codes, and I'll just show you real quick how that works. With ICD, you can go in and look at all the new, changed, and deleted codes, and they're listed out here nice and neat. You can do that with CPT, but you can't do it until January 1st.
I don't see what you're trying to share.
Okay, let me share again. Because I popped another screen on. Let me just stop screen and then let me add it back. Share screen. That one. There we go. Sorry about that. Okay, let me just go back and show you. So we can look at the new codes. So for diagnoses, here it shows us all of the new codes because there's not a copyright on ICD. So it's set up in this great format, alphanumeric, and soon when they officially release January 1st, we're allowed to do that with CPT. In the meantime, because it's got a copyright, we have to look at the sneak peek, okay? And so let me just close that. These are the some of the description changes that were made, but there's 35 pages of the changes, and then we can look at these individually. What code do I want to look at? Remember those intervascular ones that we were discussing? So here is a code 37283, revascularization, open or percutaneous, tibial, and perineal vascular territory. Because remember I said they added all those territories in there. That's why they needed that, because before it was too broad. And you'll know this for our existing coders that have been doing the BAT technique with their manuals for some time. These are the type of notes that you're bubbling and highlighting in your CPT manual so that you can distinguish these type of codes. So now a little heads up is that it'll be in the revascularization bubble, and then knowing that it's open or percutaneous, which all of these are, but location, it's tibial and perineal vascular territory. So that one, in comparison to this one, see, tibial and perineal vascular territory. But what distinguishes these two? For one, this is an add-on code, but let's see, with transluminal angioplasty, and this one's with transluminal stent placement. Now note that this code 37283 is an add-on code for 37282. But what makes them different is, let's see, with including, okay, so usually with add-on codes, you're getting into lists separately.
Yeah, they're looking for the main procedure. Right. That would be your initial vessel. And then the add-on codes are if it's another vessel done at the same session. So yes. And what's really weird about it, and a lot of new students to coding miss, is that you could have the iliac vessel be the initial, but then you can have one in a whole nother territory be an add-on code. So it's very tricky, but the guidelines are really good. I just got my electronic version of the CPT manual, and I was looking at them today, and the guidelines really explain it very well. And I'm going to be doing a topic presentation on this in an upcoming webinar, because these are very meaty, and I could probably take a whole hour just to go through them. But always just compare and contrast, and you'll get in the right family, the right procedure, stents rule, then atherectomies, then angioplasties. So you always want to, because if you have a stent in the same vessel, everything else is included, the atherectomy and the angioplasty. And then just have to figure out if there's additional vessels, use the add-on code. So
so that the one is, this is complex lesion, but this is the initial vessel, like Lauren was saying, and this is each additional vessel. But
And that's a new thing for 2026. The severity, is it complex or straightforward? And straightforward means it's a stenosis, but complex means there's an occlusion. So they tell you that right in the guidelines.
Yeah, there's the, yeah. One of the advantage though with the sneak peek is it's only, like this year it's 35 pages, but look, it's only the codes that have changed or that you need to pay attention to. It's not all the manual. So you can go through, like I had mentioned, remember in the beginning, if you work in the twos, then that's what you're going to look at, these vascular codes, the twos, threes, and so on. If you want to go down and look at the sevens for the imaging, you can scroll, you can get right down there and see what the radiation therapy and so on and so forth. So it's not overwhelming. And now we've given you the highlight. We've let you know what to pay attention to. I'm going to move this. No, it's not going to let me. I'm going to X out of that. And then I'm going to go back and share my original screen because there's a few things that we want to cover as we wrap up. Did you want to talk about any of these or do you want me to keep going, Lori?
Sure, I can do a slide here. So the club is where it's at. You can get more CEUs. Today's event will be a free CEU, but if you want more, our club is devoted to providing quite a few CEUs for the whole year. It's plenty to keep you covered for one or two credentials with the AAPC, and the AAPC credentials carry over for HEMA and other organizations. And of course, QPro is another coding organization, and all of our webinars are QPro approved.
Yep.
So check it out at cco.us/club. We have an annual membership that is currently on sale for $199 instead of $249. The price is going to go up January 1st. So get in on that. And I did want to let you know we're having a Black Friday sale that will be starting shortly. So make sure you're on our insiders list to get that email, 25% off. And that's the last time for 2025. You'll be able to get the 2025 prices at a discount.
Yep. So that also, remember I had mentioned that if you want to go, if you like the way we did that consolidated table, if you want to be able to look at that information and share that at your office, then yeah, you can, if you're in part of the club, you can do that with attribution. We have everything marked. Also, that might be a good time to say that if there's something specific that you would like us to help develop a tool, then let us know and we will absolutely jump in and help you develop that. So just reach out to us. And we wanted to give you a heads up. We worked a lot this last week on the new clinical documentation improvement course. We're excited about that. We really want to get this out soon to you. I think that it's important that this is the way we're moving. This is my humble opinion. The auditing credentials that you have out there don't carry the weight or will not carry the weight in the future that they did in the past. Right now, it's leaning more towards the CDI aspect, the educational review. So I would, risk adjustment drives revenue. So does the CPT code set. But to be able to be on top of your game, it's all about CDI, the disease process, and the diagnoses, the CPT as well. But all of that comes together when you're solid with documentation. And so again, we're real excited to be able to tell you more about that. If you have questions, tap into us. And Ronnie already said that she's going to take that course. Good. I'm glad. That is one we are real excited to be developing for you. I'm going to love it almost as much as when we did the risk adjustment course.
Alicia, there was a question about the sneak peek.
Oh, okay.
It said, is there a chance that there could be more changes? It's my understanding that what Find a Code gets from the AMA is pretty fixed. Those are the changes, and they allow them to share that PDF, and then January 1st, you'll be able to see all the new codes in Find a Code. There's particular reasons why they have to wait till the 1st, but that's how it works.
Yeah. And so this question came up, is it possible to do a webinar explaining CDI? Absolutely. As we get closer to launching, we'll do that. We'll be building up to it. And so you will see more. We've done a little bit in the past because that's something that both Lauren and I deal with in our other lives. And so you will see those. Lauren already mentioned the Black Friday sales. So know that you go to cco.us/insider. You can get more information. You guys, are any of you guys on the Academy? I know I recognize some of the names, but if you aren't, this is where things are happening. This is where we're having a lot of fun, is at the CCO Academy. I was just following on my phone today. It was some questions that had come in and just giving some people some kudos for getting through their courses and just giving them a little bit of love and encouragement. It's very interactive, easy, user friendly with devices. If you want more about that, you can jump out and look at us on youtube.com/at CCO-Academy. Yeah, the Academy, yeah.
It's actually just at CCO.
Is it? Oh, just at CCO.
Yeah.
Yeah. The Academy is wonderful. Thumbs up. You're right. I agree.
Yeah, it's been a really good change. It's very user friendly. Yeah. And a lot of people that I've been doing like welcome calls with, we won't say the name, but there's a large organization that does a lot of training, and they're like, the lectures are so boring and robotic, and the worst part is the support's really bad. So with us, you get your own private room if you are a student, and we're all in there, me, Alicia, Sylvia, the help desk staff, and we'll jump in and say, we haven't heard from you in 2 weeks. Is everything okay? They're like, and at first, like, yeah, I'm good. It's okay. We're just your cheering committee. We're just here to cheer you on. They're like, I'm not used to this from the other place. So we do track how you're scoring on your test. We go look at it and say, oh, okay, they were just doing E&M. How you got a really good score on that. How long did it take you? Or we care, and we start to recognize your name and how you're progressing. That is something we're proud of.
Message to someone this afternoon that I looked and realized that it had been a couple weeks and they didn't see a chapter come through, and just sent them a little note. And again, like Lauren said, it's okay. We have the holiday. We have lots of stuff happening and everything, and it will be pretty light the next couple months as we go through holidays. However, we don't want you to slip through the cracks. We want to make sure that you don't lose your focus. And one person had said, yeah, a lot of family issues and that they're going to take a break. No problem. We're here to help you do that. Now, Tamika, I believe the quiz is already set up in, maybe I'm just reading in the background, but you asked how long does it take to do the CEU quiz? 10 minutes, maybe 5, I think. It's 10 questions, right?
Yeah, it's not hard.
No, it's not. It's just validation that you were present. So it's about what we talked about and just confirming that you were here. And so that's important. And I believe that about does it for us. Let's see. We got all those. We've got lots. Oh, last thing. Now, several of you did this. Thank you. We made notes of the areas that you said you need more information on. So we do appreciate that. That's one of the advantages of being present on these events. You take priority, and so do our members. They absolutely take priority. If there is something specific, or if you want to give us a little more detail, then submit your topic request. Lauren's popped that in there for everybody. It's cco.us/topic-request. We really like you to do it this way because then it's into our platform and we can delegate. So we do appreciate if you do that. And Radhika says, risk adjustment, please. Woo, yay. validated.
Yeah, we've been getting a lot of interest in risk adjustment. And I think the time of year, January, is the new push for hiring, right?
Yep, that's right. That slows down. Usually get November and December, you're done. The contracts are done. Then they ramp back up. So this is the perfect time to start getting your name in there for those jobs. And let me tell you that if you're going to be going with risk adjustment, CDI, and being able to learn how to decipher and abstract from those notes and proper documentation, that's where it's at. Pharmacology, anatomy, physiology, pathophysiology, disease process, CDI, that's the, and we've created those ancillary courses to help you. Even if you're already in the industry and your credentials, you need to keep that knowledge base up. I was just talking to a director and discussing what the coder should and doesn't need to know, because and what the clinician should state versus what the coder should know. And that's CDI and your understanding of anatomy, physiology, pathophysiology. So thanks.
Thank you, everyone. And the best place to reach us now, cco.academy. And you can reach the help desk there. Alicia and I are in there. Just post a message. A lot of people are coming and getting support from each other. Our interns are on fire. They're like the welcoming committee. When someone new comes on, and they'll welcome them. So please join us there. We would love to interact with you more. And tell your friends. That is what we mostly appreciate. If you appreciate this free information, just share it on Facebook or LinkedIn or X or Twitter, like whatever you do, just to let people know. They can go right to cco.academy and join. There's a free area that's got a lot of goodies, these CEUs, discussion area, the events calendar. Get them on that, and we can grow this. And the bigger we get, the more CEUs we can bring you. And thank you.
Yep. Go out and get your CEU quiz in the club area, and we look forward to seeing you next Thursday. We're here every Thursday, guys, and so just mark your calendar that Thursdays. We'll have good content for you.
All right.
Thank
Bye,
you.
everyone.
Bye-bye.
Looking for medical coding, medical billing, and risk adjustment education? Learn more at cco.us.